Hello, everyone. Today we have another clinical case discussion with us. So let us begin. So today we have a 45 male who had a fever which was low grade with a dry cough, malaise, myalgias, rhinorrhea for about 2 days. He tested positive for COVID 19 and was under home isolation. He recovered with these symptoms in about a week, but continued to have a lower back pain which was dull aching, and now it got started associated with tingling sensation in his bilateral lower limbs. And over the next 5 days, he developed the bilateral lower limb weakness to an extent that he became bedbound and he was not able to move his legs even in the bed. Okay. But however, there was no complaint of any ocular, bulbar, neck, facial, or upper limb weakness. Okay. So 45 male who has a background history of COVID-19 recovered from it, but now from about a week's duration is complaining of bilateral lower limb weakness with a tingling sensation. Now the back pain has now progressed to a band-like sensation which is ascending from his umbilicus to upper chest, and he feels that this band is tied at the upper chest and below that he's not able to feel any sensation. Also, he's not able to pass the urine and there is an abdominal distension. Okay. There is no complaint of any loss of consciousness or seizures, no history suggestive of any cranial nerve, cerebellar, or autonomic dysfunction. Now, when you examine this patient, he is conscious oriented to time, place, and person. The cranial nerves are normal. The motor system, however, reveals a flaccid lower limbs with 0 by 5 power. I'm sorry for this. It was in the lower limbs, not in the upper limbs. Okay. The upper limb, the power was 5 by 5. The reflexes in the upper limb was 2 plus and in the lower limb was 3 plus. The plantars were bilaterally extensor with sensory level at T4. Okay. The cerebellar system was normal. The bladder was palpable, and when you had inserted Foley's, about 1.5 liters of urine drained out. So now, how do you approach this patient? So your patient has an acute onset illness, which is for about 1 week, and it is progressive. What is the pattern? It is involving both sensory and motor systems. Predominantly, it is there only in the lower limbs where it is bilaterally symmetrical. Proximal as well as distal, we have 0 by 5 power. It is flaccid, but it has brisk reflexes with a bladder involvement. Okay. So this is the pattern that you formulated. Okay. Now let us see how do you localize. So your patient is oriented to time, place, and person, is not giving you any seizures, any loss of consciousness. So your higher mental functions are intact. So can the localization be in the brain? No. Your patient does not give you any cerebellar features and your cerebellar examination is normal. So cerebellum is out. There is no cranial nerve involvement. So this brainstem is out. Okay. So at least till here, there is no localization. Your patient has both sensory and motor involvement. So the patient cannot have muscle, which is a pure motor, cannot have NM junction. Now has sensory and motor with a bladder involvement. So cannot be a nerve, cannot be a root pathology. So if you put all of these together, sensory, motor, bladder with no cranial nerves, normal cerebellar, normal cognition. So where is the localization? It is at the cord. Now you understand how you have to put together your summary into a pattern recognition and how you have to use your pattern to localize where is the lesion. Okay. So this is only the half the process. So we have localized the lesion to spinal cord, but where in the spinal cord? So now I hope you remember from the approach to myelopathy discussion that now we have localized the lesion to cord. We need to first rule out compression, then do a longitudinal localization in the cord, then the transverse localization, and then find out the etiology. Okay. So we have localized the lesion to cord. Now we move further. Now, how do we do the longitudinal localization? Okay. Now remember I told you the longitudinal localization is done by the help of myotomes, dermatomes, and reflexes. Okay. Now, your patient has weakness only in the lower limbs. The upper limbs are absolutely normal. So, lower limbs, the myotomes, they begin from L1. So, what you can confer from this information is that the lesion is going to be above the level of L1. Okay, so it is above L1, can be anywhere above L1. So, that's the minimum extent that the lesion is going to be at. Now, if you have to find out the upper extent, you need to see that the upper limb is normal. Now, upper limb, the brachial plexus is from C5 to T1. So, where is the longitudinal localization? Above L1 and below T1. I hope you all got it. The localization from the myotome, because the legs are completely involved, the lesion is above L1, and because upper limbs are absolutely okay, so the lesion is below T1. So it is somewhere between T1 to L1. Okay. Now, so T1 to L1 is still a very big segment. Now, how do we further localize it? Now we move on to dermatomes. Now remember, your patient said that he feels like a band-like sensation around his upper chest. And when you examined this patient, you found a sensory level at T4. Okay. So from myotome, you had localized the lesion between T1 and L1. Now when you bring the dermatomes into it, your lesion is now between T4 to L1. Okay. Then reflexes were brisk in the lower limb, normal in the upper limb. So that means again the localization is above L1 but below T1. So when you put them all together, your final longitudinal localization based on the history is between T4 and L1. So I hope you all understood how we do the longitudinal localization. Moving forward, so once we have done the longitudinal, the next step is the cross-sectional localization. Now in the cross-sectional, I'm very sure by this point of time, all of you would have heard the words like intramedullary, extramedullary, intradural, extradural, and majority of you, even I was very confused as a resident as to what these terms are and how do you localize here. But don't worry, we'll simplify all of that for you today. Okay, so first understand what do these words actually mean. Okay, intramedullary means within the medulla. And what is this medulla? It is the substance of the spinal cord. So anything which is within the substance of spinal cord is called as intramedullary. Understood? So intramedullary is something which is within the substance of spinal cord. Anything which is outside is going to be extramedullary. Okay. Now, extramedullary can be within the dura. It can be intradural. So it is within the dura, it is intradural, but it is outside the spinal cord substance, so it is extramedullary. Then this extramedullary can be even outside the dura, so that will be extradural. Okay. So please understand the basic concept of these terms. Only then you will be able to do a correct localization. Okay. So intramedullary is within the substance of spinal cord. Anything which is not within the spinal cord will be extramedullary, which can be within the dura, it is intradural, or it is outside the dura, it is extradural.